Hello guys, welcome to our channel. Today we are going to discuss on the anatomy rapid revision program. So in this, the most important previous year topics that we are going to discuss. So before that, please do subscribe and share with your friends. Make to reach the 1K subscribers so that it can be recommended to the all the students who are preparing for the FMG and the NEETPG. So let's start our session. So first we will discuss the different types of the triangles and the triads. All these will be discussed in the first half of the video. So first, that is your femoral triangle. In the femoral triangle, the borders are the most important. So when you see the borders, the superior border is your inguinal ligament. So in the femoral triangle, the superior border is the inguinal ligament. And in the medial one, so the medial one is your adductor longus. And your lateral side of the border is the sartorius. So the first question is what is the superior border? So the superior border is the inguinal ligament and the medial border is the adductor longus and lateral border is the sartorius. And what is the content, guys? What is the content of the femoral triangle? Remember, your femoral artery and the femoral vein is present here. And also, the femoral nerve is also present in the content. Along with that, we are also having another content that is your genitofemoral nerve. Okay, the femoral branch to the genitofemoral nerve is also present in the content of the femoral triangle. So this is the triangle. These are the contents. That is very important. And next coming to the femoral shed. Femoral shed is nothing but a covering of the specific structures within the femoral triangle. So in the femoral shed, that is subdivided into the medial side to three compartments. One is your medial compartment, and another one is your intermediate compartment, and another one is your lateral compartment. And what is the content that is present in these three compartments? In the medial one, we have the lymph nodes. So the deep lymph node is present here. Here you can see this is the lymph nodes. And next coming to the intermediate one, here your femoral vein is present. And in the lateral side, your femoral artery. Here you can see these are the different compartments that is located in the within the femoral shed. And in the lateral of the femoral artery, and along with that, again here genitofemoral nerve is present. So this is what the femoral shed and the within the compartments and the contents. Next, moving on to the popliteal fossa. Okay, this is your popliteal fossa. In the popliteal fossa, what are the presentation that is present in this content? So in the popliteal fossa, this is the exactly in the posterior side of our popliteal region. So this is your borders of the popliteal fossa, and the lower border is your gastroscleneus muscle. So the gastroscleneus muscle is the medial and the lateral side of the both in the downside. But in the above side, the medially is your semimembranous, and the laterally is your bicep femoris. And here also the content is most important. What is the content? The popliteal artery and the popliteal vein. Along with that, you also have the tibial nerve, okay, and also the sciatic nerve. The tibial nerve, the sciatic nerve, and along with that, you also have the common peroneal nerve. Okay, the common peroneal nerve is also present in this fossa. Next, moving on to your anatomical snap box. So in the anatomical snap box, this is also the commonly asked question in your examination in the previous examinations. So in the structure of the anatomical snap box, here you can see what are the borders of this anatomical snap box. Here the first thing that we have to remember, the tendon, that is the extensor pollicis longus, is the superior one of the border for the anatomical snap box. Along that the border is on the inferior side, that is closed by the tendon of the adductor longus, abductor pollicis longus, and extensor pollicis longus. Pollicis means that is your thumb. So which are going towards the thumb, that is known as the pollicis. Longer is the long one of the tendon, and the shorter one is the brevis. That is your extensor pollicis brevis. And what is the content, guys? The content is your radial artery. And when the anatomical snap box is painful, when there is a scaphoid fracture. So the scaphoid is the carpal bone. If the scaphoid bone is fractured, then there is a pain is present in the anatomical snap box. Next, moving on to the cubital fossa. Cubital fossa is also commonly asked question. And what are the boundaries of this cubital fossa? The superior boundary of the cubital fossa is your superior border of the epicondylar line. Okay, this is your superior side. And on the lateral side, this is your lateral side, that is your brachioradialis. And medial side, that is your medial border of the pronator series. And again, what is the content of this structure? So the content is simply the mnemonic should be remembered as a MBBS. What is the MBBS? M for median nerve, M for median nerve, B for brachial artery, and B for brachial vein, and S for superficial radial nerve. Alright. This is the content that is present here. Here you can see the superficial radial nerve, and also this is your brachial artery, brachial vein, and also this is your median nerve. So remember like this. From the medial side to the lateral side, how it is like this. MBBS. This is the mnemonic that we have to remember. And next coming to here. And by looking at this picture only, you have to remember this is the Redlenberg test. Okay, this is your Redlenberg test. What is the significance of the Redlenberg test, guys? So we have the three muscles in the gluteus muscles. What are those muscles? One is your gluteus maximus, and another one is your gluteus intermedius, and last one is your gluteus medius. So the gluteus maximus is the nerve that is supplied by the inferior gluteal nerve. Okay, that is your inferior gluteal nerve. And what about these two, gluteus intermedius and the gluteus minimus, that is your superior gluteal nerve. Superior gluteal nerve. So in case if the patient is having the superior gluteal nerve palsy, what happens when you ask the patient to stand on the one leg only? So usually in the normal patient, when you ask the patient to stand on the one leg, what happens in the normal side? The lifted leg will be, the hip will be upwards. So there is no sagging in thing. So usually this is due to the stability of the superior gluteal nerve. What happens in the palsy patients? So even though when the patient is standing on the here you can see the patient is standing on the one leg, so the sagging should be on the normal side. So this is the normal side, this is the abnormal side. If the patient is standing on the one leg which is affected, so the pelvis is going to sagging on the normal side. This is due to the superior gluteal nerve palsy. And next coming to the another picture based question. So here you can see this is the shoulder dropping is seen. Why? Usually the shoulder shrugging or the shoulder stability, sternocleidomastoid muscle stability is seen in which patients? So this is in the spinal accessory nerve patient. So if the spinal accessory nerve is palsy, so the patient likely to be having this condition. Okay, this is spinal accessory nerve palsy. Okay, here you can see the shoulder drop. And next coming to the this kind of scapula. What is this kind of scapula is known as winged scapula. So in the winged scapula, what is the condition that is palsy is causing this head? That is your long thoracic nerve. Okay, remember this is due to long thoracic nerve. So you have to remember this. Next. So this is how we completed the first half of the triangles, fossa, and also important their contents. So next moving on to the another system like abdominal, these planes is also very important. So in the abdominal region, when you see the dermatomes, the T10 dermatome. What is the T10 dermatome? That is the umbilicus. Okay, that is the umbilicus. And next the L3 and the L5. So your L3 is here. Okay, your L3 is here and L5 is here. So L3 is the subcostal plane. Okay, this is also asked question previously. What is the L3 signified? That is your subcostal plane. Here you can see this is the subcostal plane. And next one is your L5. L5 is the transtubercular plane. Okay, this is your transtubercular segment. These are the things that you have to remember. L3 is for the subcostal vein, T10 for the umbilicus, and the L5 is for the transtubercular vein. And next one is your Callout triangle and the hepatocystic triangle. Here you can see this is the Callout triangle. What are the borders of the Callout triangle? Guys, the superior border is your cystic artery. Okay, superior border is the cystic artery. And next one is your the lateral medial side, that is the common hepatic bed. Okay, common hepatic bed. And the next one is your cystic bed. On the lateral side, it is your cystic bed. So the triangle in the Callout triangle, which is most important for the lap cholecystectomy or the collateral open cholecystectomy, which we are emphasizing its importance. Okay, in this patient, if we are checking the cholecystectomy, we have to take note of this Callout triangle because this is very, very important. The cystic artery. If there is in case bleed or the sudden rupture of this cystic artery due to any iatrogenic, due to our surgeon side or the patient. So what happens? There is a high chance of the bleeding will occur. So that's why the Callout triangle is important. And what is the hepatocystic triangle? Hepatocystic triangle, all the borders are same. So the common hepatic duct on the medial side, cystic duct on the lateral side. What is the superior one? In the superior border, it is inferior liver border. Okay, inferior liver border. So this is your, here you can see this is the inferior border of the liver. That is the superior border. So this is only difference between the hepatocystic and the Callout triangle. Next, moving on to the inguinal canal. So inguinal canal, first thing that you have to understand, what are the layers of your abdomen. Here you can see the layers of the abdomen is the first one, that is your external oblique muscles. So external oblique muscles, and after that the internal oblique muscles, there is a transversalis abdominis muscle and the transversalis fascia. So this is how the inguinal canal layers is formed. So if you see the inguinal canal, how this is formed means, here you can see this is the inguinal canal, guys. So this is your roof, this is the base, okay, and this is the anterior side, this is the posterior side. So what are the structures that is present here? So on the roof, there is a conjoint tendon. Okay, the conjoint tendon. How this conjoint tendon is formed? So the conjoint tendon is formed before. So the conjoint tendon is formed by the internal oblique muscles and also your transverse abdominis muscle. So these two muscles is going to form the conjoint tendon of the roof. On the anterior side, the mostly your external oblique muscles. And on the posterior side, that is your transversalis fascia. And on the base side, is your inguinal ligament. Okay, that is your inguinal ligament. Here you can see this is the inguinal ligament. So this is how the inguinal canal is formed. So the between here, so this is where the content is formed and then transferred to the downside of the inguinal junction. So next here, another triangle that is seen, that is your Hasselbeck's triangle. Hasselbeck's triangle and its borders also very, very important. So in the Hasselbeck's triangle, the medial side is your rectus abdominis. Okay, here you can see this is your rectus abdominis side. On the medial side is your rectus abdominis. And on the inferior side, so on the inferior side is your inguinal ligament. Here you can see the inferior side is the inguinal ligament. Next, on the lateral side is your inferior epigastric vein. Okay, not only the vein and also inferior epigastric vein. And there is also the common question asked here, if the patient is having the inguinal canal defect, what is the most commonly involved nerve? The most commonly involved nerve is your ilioinguinal nerve. So if there is a defect within the inguinal hernia, so there is a high chance of the ilioinguinal nerve damages. So this is also once upon a time asked question. Next, coming to the liver segment, this is the last 2024 June question. What is the segment that has to be identified? So for that, just remember until 4 only. So this is your 1, 2, 3, 4. And remember the 8th one. So the beside to the 4th one is your 8th one only. So 4B, 5, 6, 7. So like that. So 1, 2, 3, 4, 5, 8. 5, 6, 7, using you can remember. So this is how the differentiation of the liver segments that has to be remembered and identified. So here completes another topic. And next moving on to the mediastinum. So in the mediastinum and the mediastinum contents is also very, very important. So first thing that is mostly referred as a superior. So mediastinum is divided into the two types. One is the superior and another one is the inferior. Okay. In the superior, what are the contents is present? Here you can see the differentiation. This is the superior one. And this 3 is the inferior one. In the inferior one, that is subdivided into the anterior, there is anterior, and this is the middle one, and also this is the post one. So these 3 are the branches of your inferior. Okay, these 3 are the branches of your inferior. Let's see what are the contents that is passing through this superior, inferior, anterior, middle, mediastinum. So in the superior one, the contents that is commonly, usually what we said in the superior mediastinum, what are the contents that is passing is the first one is your ascending aorta. Ascending aorta and the thoracic duct. Trachea, esophagus. Wherever the esophagus is formed, the vagus nerve is also present. Alright, and then also your phrenic nerve and the left recurrent laryngeal nerve, sympathetic trunk. So this is the content of the superior mediastinum. And in the inferior, what we have discussed, first is your anterior. In the anterior, you have only the two, that is your thymus and also free fatty tissue. Free fatty tissue is formed in the anterior. Next one is the middle one. In the middle, we all know one is the major one, that is your heart, and other one is the brain and the pericardial tissue. And on the posterior side. So posterior side, mostly except the trachea, most of are the same movie. For example, if you see the first thing is your esophagus, along with that, instead of the ascending aorta, here the descending aorta is passing through. And the recurrent laryngeal nerve is not here because the laryngeal nerve is on the upper. The phrenic nerve is already passed in the middle one. So the only nerve that is passing here is the vagus nerve and sympathetic nerve and inferior vena cava and also your thoracic duct. So these are the structures that is passing in the posterior intestine. So these contents and their passing through the mediastinum are very, very important. Next, moving on to the openings of the diaphragm and what are the structures that is passing through this. So it is subdivided into the 3 levels. Guys. Here you can see this is the central tendon and this is your esophageal hiatus and this is your caval hiatus and also aortic hiatus. So where are these levels? So usually your phrenic nerve roots are very important. So the phrenic nerve, instead of phrenic nerve, remember like this as a phrenic nerve. Okay, 3 nerve roots are present here. That is your C3, C4 and C5. These are the nerve roots. And what are the structures that is passing? At the T8, the vena cava hiatus. What are the structures? Inferior vena cava and the right phrenic nerve. And the T10 is your esophagus opening. Here esophagus, vagus nerve and also esophagus branch of the left gastric artery is passing. And the T12 is the aortic one. Only the aorta, thoracic duct and the arterial vein passing. So these 3 structures and this is your T8, T10 and the T11. So their contents are structures passing to the very, very important to remember. Next, moving on to the heart, coronary circulation and what is the sides of the leads and the involved patterns. Let's see here the anterior side of the circulation. We all know that the arteries are subdivided from the coronary sinus into the right coronary artery and the left main coronary artery. So left marginal artery subdivided into the left circumflex artery and anterior interventricular artery. So this is the three arteries that is anteriorly most common. And the right coronary artery is going to supply for your SA node, AV node, and also this is going to supply to the other right marginal and the inferior part of the artery. And also when you turn to the back side, I mean the posterior side of the heart also, right coronary artery is the major artery and the more dominant artery. Alright. So we all know that we are going to place this as a leads, right? The V1, V2, V3, V4, V5 and the V6. And also other leads we have the 1, 2, 3, AVF, AVL and the AVR. So where these leads are placed and what are the walls that is involved in this condition. So first thing that you have to remember, the 1, 2 AVF. The 1, 2 AVF involves your inferior. Okay, and your V5, V6 that will involve the lateral. Sorry. This will involve the lateral one. Okay. So the V1, V2, V3, V4 will involve the anterior septal. Okay, this will involve the anterior septal. So this is how we have to find out where is the most common culprit of the arteries involved. So in the lateral side, if I say the lateral side, that is your left circumflex artery. And in the anterior septum, that is your LADA. So LADA is the most common for the coronary artery disease, right? And the inferior side, that is your RCA. And in the posterior side, if it is involved also, that is also RCA. So this is how you have to differentiate in the arteries. So next, moving on to the urethral trauma. This is also commonly asked question, right? So first thing that you have to understand, what is the commonly the urethra and what is the different parts of the urethra. Here you can see this is the urethra. It is subdivided into the prostatic urethra, membranous urethra, bulbar urethra, and the cranial urethra. So the most common trauma is also involved the membranous urethra and the bulbar urethra. So let's see differentiation. In the membranous urethra, so the common injury this is due to pelvic fracture. So if the patient is having the pelvic fracture, likely to be the membranous urethra is going to damage. In the membranous urethra, what happens? These patients commonly only involves the deep peroneal pouch. Okay, the deep peroneal pouch is involved. So if the urine is leaking, it will leak in the deep peroneal pouch and also prostate because it will ride upwards, right? So here only the structure very near to the prostatic urethra, so it will travel upward to the prostate. And also no scrotal hematoma. So the scrotum is a very far from the membranous urethra. So there is no scrotum hematoma in this patient. Next, moving on to the bulbar side. So what happens in the bulbar side? This is a very serious injury. So the patient goes for having the straddle injury is likely to be injured with the bulbar. So here the bulbar, right? The bulbar is injured means this is the Buck's fascia. So if the Buck's fascia is also torn, what happens? This will leak into the superficial pouch. Superficial peroneal pouch, it will be going to leak. And then it is also going to involve the scrotum. So if it is involved the scrotum, what happens? There is a hematoma also formed in the scrotum. So here you can see the Buck's fascia. Buck's fascia is damaged. So there it will going into the anterior abdominal wall. So there is going into the anterior abdominal wall. Does it involve the peritoneum? So it does not involve the peritoneum. Okay, this is how the where is the structure that is involved, where is the urine is used in this urethral trauma. And next moving on to the nerves and their supplied. So the purely we have the 12 cranial nerves, right? So in the 12 cranial nerves, which are the most sensory nerves? So the sensory nerves are your one, that is your olfactory and your optic nerve and your vestibulocochlear nerve. These are the three nerves are your sensory nerves. And coming to the motor is your oculomotor, abducens, and the trochlear, and also your 11th and the 12th cranial nerve. And completely the parasympathetic nervous system nerves are your third nerve, seventh nerve, and ninth and 10th nerve. These are the purely parasympathetic nervous system supplied now. So you have to remember what are those sensory, motor, and parasympathetic nerves. All right. Next. Moving on to the pharyngeal arches and their structures is formed. Remember only the one thing that you have to remember: what are the arteries, the nerves are involved in the pharyngeal arches, because this is commonly asked from the past examinations. Let's see, your first arch is going to give for the mandibular artery and your maxillary nerve. So the structures nearby the mandibular and the maxilla are going to be derived from your arch one. And next, your second arch is going to be for the stapedial nerve, the stapedial artery, and for your facial nerve. And the third arch is going to be for the glossopharyngeal nerve, and for your carotid arteries. So the structures is which are in the neck region is going to derive from the third arch. So the fourth arch is going to reach for the arch of aorta, and the nerves are your superficial laryngeal nerves. There is no fifth arch. The sixth arch is going to be for the ductus arteriosus in the fetal circulation, and after that the right and the left pulmonary arteries, and the nerve is the right recurrent laryngeal nerve. Okay, this is the how the arches and their arteries and the nerves are derived from them. Okay, next moving on to the nerve supply of the tongue. So the basically the tongue is divided into the anterior two-third and the posterior one-third and the basal side. So this is how the separately differentiated. So the motor nerve supply. Usually the motor nerve supply is the hypoglossal and the vagus nerve. So all the muscles are supplied by the hypoglossal. So all are by the hypoglossal nerve only. So the only that is separate except is your palatoglossal. So the palatoglossal is supplied by the vagus nerve. So that is only the difference. And next coming to here, the general sensation. So the general sensation is by the lingual nerve, but the taste sensation is by the caudate implant. This is for the anterior two-thirds. And the posterior one-third, the both general and the taste sensation is by the glossopharyngeal. And coming to the basal side, by your cranial nerve 10, that is the branch of the superior laryngeal nerve. This is the supply of the tongue. All right, next. So this is the hypoglossal nerve injury. So in this patient, this is the normal side because the structure is intact. So this is the atrophy. Okay, this is the nerve injury. So since the action is present here, so that's why the tongue is going onto the contralateral side. So this is the tongue palsy due to hypoglossal nerve injury. All right. Next, mastication muscles. What are the masticated muscles, guys? That is your atrial pterygoid, and your medial pterygoid, masseter muscle, and the temporal. These are your mastication muscles. Next, moving on to the cranial nerve defects. All right. So, in the cranial nerve defects, what are the types that we have to understand? So, two types. One is your anterior cranial nerve defects and the posterior cranial neural defects. Okay. So, in the anterior one, when it is closed. So, basically, it is started in the second week like that. So, when it is going to end, usually it is going to end on the 25th intrauterine line, or you can say the third week of the intrauterine line. And the posterior one that is going to close on the 28th week by usually fourth week. So, the most common one or the most severe one in the anterior cranial nerves is the anencephaly. Here you can see this is the anencephaly. And next one is the most specifically, if they say the most specific, that is your craniobrachyscephaly. All right, that is your craniobrachyscephaly. Next, the posterior cranial nerve, the posterior neural tube defects are the most common one is the spina bifida, and this is also the overall neural tube defects, posterior or the anterior, overall is the spina bifida only. So this is the spina bifida, and most severe in the posterior side, that is your myelomeningocele. So that is your myelomeningocele. Next, moving on to the these conditions. So the gastroscopy and the omphalocele. So what is the difference between the gastroscopy and the omphalocele? This is your omphalocele, this is your gastroscopy. So the omphalocele, here you can see the defect is came from the abdominal. So umbilical cord only is came. Umbilical cord. And there is a covering that is present. So the covering is also present here. And this is associated with the more genetic defects. So this is what the omphalocele. And gastroscopy is not coming from the umbilical cord. This is actually coming from the anterior abdominal wall defect. And no covering is present. And no genetic defects. And in the both conditions, what we have to do, we have to enclose this structure. Close this structure, and so by the time of the operation, you have to reduce by your hand or you have to repair it immediately. Because if there is an exposure, there is a high chance of the necrosis of the bowel injury is seen in this patient. So this is what the gastroscopy and follow see. So the last topic that we are going to discuss here is the cranial nerve palsy. So especially which now guys, we are going to discuss about the facial nerve. So in the facial nerve, we have the two types. One is your upper motor nerve injury and the lower motor nerve injury. So in the upper motor nerve injury, what is the specifically the structure that is involved here is the contralateral injury. So the lesion is on the right side, let's say, but the lesions that is going to present in the left side. So the contralateral symptoms is present. In the contralateral also, only the lower face is involved. All right, the lower face is involved, and the forehead is there. And the lower motor injury, it is going to involve the ipsilateral. So the lesion is on the this side. So this is also going to involve on the same side. So the ipsilateral injury is in this patient. So the whole face is involved. Even the forehead is also involved. So that is what is the condition between the upper motor and the lower motor of the patient. And the drooping of the mouth on the same side. Okay. So the drooping is seen on the lesion side only. So same with this side. So the drooping is also seen in the same side. the final topics. One is your epithelium, guys. So in the epithelium, you have to remember simple squamous, simple columnar, pseudo-stratified, stratified squamous, and also your transitional epithelium. What are those? Examples is very very important. Simple squamous epithelium, only the single layers is presented. On the single layers, like your alveoli, like lungs region, blood vessels, your endothelium, right, and also lymphatic vessels. These are the structures that is covered by the simple squamous epithelium. Next, simple columnar, which will be present with the ciliated structures. What are the ciliated structures? Like your digestive tract, bladder, and also your uterine tubes, bronchi, all these structures will be presented with the simple columnar. And the pseudostratified, mostly your upper respiratory tract. From the trachea, so much of the bronchioles, all will be consist of the pseudostratified columnar. Next, stratified squamous epithelium is the multiple layer structure, right? Your esophagus, mouth, vagina, all will be consist of the squamous epithelium, stratified squamous epithelium. And the keratinized, non-keratinized will be differentiated separately. Next, coming to the another one, that is your transitional epithelium. Transitional epithelium, where it is present, your bladder, urethra, ureters, all these structures will be consist of the transitional epithelium. Next, moving on to the pulse points. Pulse points directly asked by your image-based question. So in that, the commonly asked questions are your radial artery at the anatomical snap box, brachial artery on your cubital fossa, femoral artery nearby your femoral triangle, inguinal region, and the popliteal artery at the popliteal fossa, the posterior tibial artery on the dorsal is pedis artery. These are the pulse points that is asked by the image-based questions. So we have covered some of the points in the tribular PDF also. Please go through it once. So what are the one more important point is your esophagus structure. For example, here you can see this is the esophagus structure. Okay, almost it is consists of the 40 centimeters. So there are some points like structures is going to coincide with the other one. For example, from the lower inside the tooth at the sulcopharyngeal junction, it is at the 15 centimeters. And where is the arch of aorta? At the 23 centimeters. In one of the PYQ, it is given at 25 centimeters. Even though if it is a 25 centimeters, please choose the arch of aorta only. And the crossed by the left bronchus, it is not the right bronchus, don't confuse. Left bronchus is the 28 centimeters. And the diaphragm is the 40 centimeters. So this is also one of the most important topics for your examination. Next point is your circle of Willis. So in the circle of Willis is also commonly asked question. For example, here you can see the vertebral artery is going to give the two sets of the spinal arteries. What are those guys? One anterior spinal artery and the two posterior spinal artery. It is going to supply by your vertebral artery. And the vertebral artery is going to give rise to your basal artery. So this is the basilar artery. And basilar artery is going to supply for your cerebellum. With the help of the anterior inferior cerebellar artery and superior cerebellar artery. And what are these pontine arteries? Like your labyrinth artery and also pontine arteries, like your pons medulla supplied by your pontine arteries. So the vertebral artery is ends up with the final branch, posterior cerebellar artery. These posterior cerebellar cerebral artery is going to communicate with the this is your ICA. So the posterior cerebellar artery should communicate with the ICA with the help of the posterior communicating artery. So this is what your circle of Willis. How the circle of Willis is formed? With the help of the internal carotid arteries gives rise to the anterior communicating artery and also posterior communicating artery. So going to coincide with the forming the circle of Willis. And next important PVQ images, you have to remember the vertebrae, right? So in the vertebrae, immediately anterior to the vertebrae is your descending aorta. So anteriorly to the descending aorta, that is your left atrium. So the left atrium followed by your left ventricle. Okay, like this you can remember the left atrium, opposite to that the right atrium. So the most anterior one to the sternum is your right ventricle. So this is also commonly asked question for you. For examination, they have asked about the thalamus, quadrate nucleus, corpus callosum. So commonly asking questions should not be ignored. So please do refer the images from the previous year topics, previous year examination on the all the anatomical sections. So that is very, very important. Please do watch this video, share with your friends, subscribe to the channel, and also understand the importance of the anatomy, which is a very good scoring subject in your paper. So all the best. Happy vacation. And please do access to our new RR notes. This is the best notes that I can recommend for you. And please do subscribe to our YouTube channel. Soon we are going to update the expected topics and the rapid revision of the other subjects.